1. Dysfunctional cognition. A central tenet of the cognitive theory of anxiety is that abnormal fear and anxiety derive from a false assumption involving an erroneous danger appraisal of a situation that is not confirmed by direct observation. The activation of dysfunctional beliefs about threat and associated cognitive processing errors leads to marked and excessive fear that is inconsistent with the objective reality of the situation. For example, the sight of a loose Rottweiler charging toward you with teeth bared and raised fur on a lonely country road would likely elicit the thought, "I'm in grave danger of being attacked. I better get out of here fast." The fear experienced in this situation is perfectly normal because it involves a reasonable deduction based on an accurate observation of the situation. On the other hand, anxiety elicited by the sight of a toy poodle dog held on a leash by its owner is abnormal. The threat mode is activated. For example, "I'm in danger," even though direct observation indicates this is a non-threatening situation. In this latter case, we would suspect that the person has a specific animal phobia. 2. Impaired functioning. Clinical anxiety will directly interfere with effective and adaptive coping in the face of a perceived threat, and more generally in the person's daily social or occupational functioning. There are instances in which the activation of fear results in a person freezing, feeling paralyzed in the face of danger. Barlow notes that rape survivors often report physical paralysis at some point, anxiety, a common but multifaceted condition 7 during the attack. In other cases, the fear and anxiety may lead to a counterproductive response that actually increases risk of harm or danger. For example, a woman anxious about driving after being involved in a rear-end collision would constantly check her rear-view mirror and so pay less attention to the traffic in front of her, increasing the chance that she would cause the very accident she feared. It is also recognized that clinical fear and anxiety usually interfere in a person's ability to lead a productive and fulfilling life. Consequently, in the Diagnostic and Statistical Manual of Mental Disorders, marked distress or significant interference with a person's normal routine, occupational or academic functioning, or social activities or relationships is one of the core diagnostic criteria for most of the anxiety disorders. 3. Persistence. In clinical states, anxiety persists much longer than would be expected under normal conditions. Recall that anxiety prompts a future-oriented perspective that involves the anticipation of threat or danger. As a result, the person with clinical anxiety can feel a heightened sense of subjective apprehension by just thinking about an impending potential threat, regardless of whether it eventually materializes. Thus, it is not uncommon for anxiety-prone individuals to experience elevated anxiety on a daily basis over many years. 4. False alarms. In anxiety disorders, one often finds the occurrence of false alarms, which Barlow defines as marked fear or panic that occurs in the absence of any life-threatening stimulus, learned or unlearned. A spontaneous or uncued panic attack is one of the best examples in a false alarm. The presence of panic attacks or intense fear in the absence of threat cues or very minimal threat provocation would suggest a clinical state.